next session of IR hepatobiliary, and it's my pleasure to share Professor Dr. Amra Abdelal, the eminent hepatic surgeon, Professor Dr. Hassan, and thank you very much for attendance. First speaker will be introduced by Professor Wissam, but it's the moderator of the session.
Okay. We will introduce our first speaker, Professor Praveen Pedu. We'll speak about the irreversible electroprotein electroporation of liver tumors.
Thank you, Chairman, and the committee here. Again, glad to be here in Egypt, and I'm going to talk a little bit about irreversible electroporation in the management of liver tumors. So these are my disclosures. And what is irreversible electroporation, and how is it different from ablation? Now, conventional ablative techniques, they use extreme temperatures to cause tissue destruction, whereas these techniques are not suitable when you're treating tumors in critical locations within the liver. For example, tumors close to the gallbladder, tumors close to the bile ducts or major vessels. These thermal ablations can cause complications. So irreversible electroporation is there to fill that space. It's a normal ablation technique that takes advantage of the electric membrane potential that exists across the cell membrane. So application of high voltage electric field, what it does is it disturbs the electric membrane potential and it creates nanopores within the cell membrane. And these nanopores will cause exudation of cell contents, and that results in cell death by apoptosis. Okay, this is a schematic illustration of how this technique works. Here is a cell, and if you apply high voltage electric field on either side of the cell, what we then do is create these multiple holes within the cell membrane. These are called nanopores, and that's why the technique is called nanoknife. And these nanopores will result in exudation of the cell contents, and the cell becomes unstable, and eventually cell death occurs, and cell death occurs by apoptosis. And macrophages come and remove the dead cells, so you see very little in the way of scarring after a treatment like this. What are the advantages of IRE? There's been a lot of animal studies that have been done in the past sort of 10 years to demonstrate the efficacy and the use of IRE. IRE produces a sharply demarcated treatment area compared to a conventional microwave ablation or a radiofrequency ablation. The main advantage is it spares the connective tissue architecture within the treated zone. So that means any structure which has got fibrocollagenous element to that, it's spared. So there is sparing of vessels and the bile ducts. And more importantly, IRE relies on electrical energy and not thermal energy. So there's no scope for a heat sink effect, which you often see with thermal ablations. This is an example of IRE ablation in a swine liver, and you can see the treatment zone is very clearly demarcated. And most importantly, if you see the major vessel, which is a hepatic vein transgressing the area, it's completely unharmed. And if you see the same area in microscopy, you can clearly see that there's a lot of tissue destruction, but the major vessel within the treated zone is completely left intact. Okay, and if you look at the high power electric field, histological field, what you see is not just the major vessels, but also the minor vessels and the bile ducts within the treated zone are completely unaffected by the actual treatment. And this is the H&E staining of the same tissue, again clearly showing a clear histological demarcation between the treated tissue on one side and the untreated tissue on the other side. So this is a Professor Meiring study from Amsterdam. What he did was he treated a pig's liver by placing 4 needles on either side of the pig's hilum. And this is what he found. You can see the amount of destruction of the tissue all around the hilum, but the actual, if you look at the histology, the fibrocollagenous structure, here, for instance, around the bile duct, around the hepatic artery and the portal vein, all these collagenous structures are completely left unaffected. So the hilum remained intact, although there's a lot of tissue death all around that. So IRE equipment is not dissimilar to a microwave. The IRE comes with a large conductor like this, which is coupled to a standard Windows-based computer. And in the front of the machine, there are there are places where you can plug these monopolar needles. These are thin monopolar needles. You can plug up to 6 of them in front of the machine, depending upon the size of the tumor and the amount of treatment zone you're expecting to create. And because we are treating tumors in an organ which are very close to the heart, you have to synchronize the electric pulse delivery to the heart rhythm, otherwise you will cause cardiac arrhythmias. So that's why the ECG synchronizer plays a role here. So what does IRE do in the liver? IRE is not there to replace thermal ablation. Thermal ablation still remains the standard of care for majority of the tumors that can be treated with a percutaneous ablation. IRE only supplements thermal ablation. It can be used in tumors that are considered to be high risk for thermal ablation. For example, tumors that are close to the hilum of the liver, tumors that are close to the bile ducts or to the major vessels. IRE can be done both percutaneously and intraoperatively. It can be done with CT guidance or ultrasound guidance when you're doing it percutaneously. But if you're using it as an intraoperative procedure, you have to use obviously ultrasound guidance. The setup for IRE is similar to a microwave. So often what you need is a CT which has got CT fluoro ability. So you can place these multiple needles, and you have to have the ability to reconstruct the needle placement in multiple planes, so that you know those needles are nice and parallel to each other, and they're nicely bracketing the tumor in order to make sure that you treat the tumor effectively. Anesthesia is important here. The anesthetist whom you're working with should be fully aware of the procedure you're doing. So normal microwaves, we tend to use it with strong sedation. They don't always intubate the patient. But for NanoKnife, we insist on patients getting intubated and completely paralyzed, because NanoKnife uses high voltage electrical energy, so you tend to cause neuromuscular stimulation. You can cause a lot of neuromuscular activity, and you can cause twitching within the patient. So it's important the patient is completely paralyzed and ventilated for the procedure. It's generally well tolerated in all patients. There's no major issues, just like any microwave. The maximum tumor size is 3 centimeters or less in order to get the ablation zone you want. Tumors more than that you can still treat with overlapping ablations, but the procedure becomes more and more complex if you're treating larger tumors, because it requires multiple needle placements, I'll explain later, and that means higher chance for local residual disease or recurrence. Okay. And as I mentioned before, this is not here to replace microwave. It's here to supplement microwave ablation or radiofrequency ablation in the liver, specifically for those tumors which you think are at higher risk for a thermal ablation. Okay. So the contraindications for IRE are pacemaker and cardiac arrhythmias. If the patient has a pacemaker and if he is dependent on the pacemaker, then IRE can cause disturbance in the pacemaker activity, so he cannot really use that. And patients who have got uncontrolled cardiac arrhythmias, uncontrolled fast atrial fibrillation, things like that, they're not suitable, because IRE works with synchronization to the heart rate, and if you do not have a stable heart rate, then the machine does not deliver the energy, and so it's not going to work. Presence of metal stents is a controversial subject. Any metal in the treated zone can cause aberration in the electric field. It can cause aberration of the electric currents, which means you have to work with lower voltages, and that affects the efficacy of the treatment. So metal stents are generally a relative contraindication to this procedure. One of the important aspects of this procedure, unlike microwave ablation or radiofrequency ablation, is the needle placement. Needle placement is absolutely critical to your results. You need to have you need to have the needles exactly 2 centimeters apart, ideally, and should not be too close, and also try these needles to be as parallel to each other as possible, because if the needles are too wide, you tend to get a very shorter constricted ablation zone, which means you will leave tissue behind. So technically it's a more demanding procedure compared to a standard thermal ablation. Here is an example of a 2 centimeter tumor. It's very important that you bracket the tumor with 4 needles like this. And then once you put the distance in the machine calculates the ideal voltage that delivers between those needles, and it sort of starts the treatment in these needle pairs until it completely ablates the treated zone. So needle placement is absolutely important in order for us to make sure that we are treating the tumor completely. So here is, I'll give you some examples. This is one example of a patient who's got multifocal HCC. This is the 2 centimeter or 2.5 centimeter HCC, very close to the left portal vein and also the left hepatic artery, and also more importantly the left duct. He also had other tumor here, which is at the periphery. That's not a major problem. And there was another tumor at the edge here. So this is the portal vein, portal venous phase of the same patient. And this is what has happened. So we placed 4 needles all around, and then we realized that the distance between the diagonal needle sets is higher than 2 centimeters. To avoid incomplete ablation in the middle, we put a central needle as well. So we treated with 5 needles here. And this is the immediate post-treatment CT scan. So we treated this area with IRE. We treated the other 2 areas with microwave ablation at the same sitting. And you can see that the treated zone, the ablated zone, looks completely, encompassing the tumor, but more importantly, the vessels, the portal vein and the bile ducts within the treated zone are left unaffected by the treatment area. This is another example where IRE is extremely useful. You've got a small neuroendocrine tumor here in a patient, neuroendocrine metastases in a patient in a critical location. It's right next to the retrohepatic IVC and also the right hepatic vein. So a conventional microwave ablation can definitely cause damage to the vessels and also reduce the efficacy of the treatment because of the heat sink. And again, IRE fits in very nicely with that sort of scenario. Here we have put 3 needles all around. Because it's such a small tumor, we only put 3 needles, and we managed to create an ablation zone which looks like that on the immediate post-treatment scan, and 3 months later looks like that, where the tumor is completely treated. Another example of where IRE is extremely useful. Here we have a patient with a small HCC situated between the middle and the left hepatic veins here. So again, not suitable for thermal ablation, too small for perhaps chemoembolization, which would have been the other alternative in this situation. So we treated the patient with, again, 3 needles here, needles going parallel to the tumor. And this is the immediate post-treatment scan. You tend to see a large ablation zone with some hyperemia around that. That is expected. And then once you do a follow-up scan, you can see that the tumor is treated, and more importantly, the 3 major veins are left completely intact, and there's no vascular damage from the procedure. Another example where IRE fits in, this is a patient who had a large cholangiocarcinoma. He went on to have an extended right hepatectomy, and we also had to replace the retrohepatic IVC with a PTFE graft. But unfortunately, 3 months after the treatment, he developed an area of recurrence adjacent to that PTFE graft. So what that meant was we couldn't use a thermal ablation because you could damage the venous outflow to the remnant liver here. So we did IRE again for this patient, and again it produced a good result, and he remained disease-free for about 18 months, and again he developed some more recurrence, which again we treated with IRE, and he still remains alive to this date. This is now 8 years post-procedure. So here is an example of a small HCC, again very close to the gallbladder, so not ideal for thermal ablation. You could still do thermal ablation by installing, doing some hydrodissection or putting cold saline in the gallbladder, and again that carries its own issues. Again, IRE fits in very nicely in this situation. You can treat this patient, treat this tumor with needles, with IRE needles, and you can get good results as well. Here, this is a follow-up scan performed at 3 months, again showing complete ablation of the treated zone. And what is important is you see very little in the way of scarring after an IRE compared to microwave. This is where intraoperatively you can perform IRE. This is a patient who's had multiple neuroendocrine metastases in the liver. He was planned for a extended right hepatectomy. You can see there are multiple lesions in the right lobe, but there is one critical lesion here, just at the very close proximity to the left hepatic vein. There is another small lesion just there. So what we did was a procedure called ALPS procedure, which I'm sure my surgical colleagues will be familiar with. So during the stage 1 resection, we dissect the right lobe. We ligate the hepatic vein, we ligate the portal vein, but we keep the hepatic artery and the bile duct intact. During the same procedure, what we did was my surgical colleague called me into theatre to do IRE to this lesion, which is what we did, just to make sure we do not damage to the remaining outflow to the liver here. So we did IRE to this lesion here, and I also did a microwave ablation to this small lesion at the edge here. So, and the patient went on to have an uneventful stage 2 liver resection, where we removed the remaining right lobe, and you can see the outflow, the left hepatic vein is preserved. So this is the follow-up scan, the DPET scan, which was performed 6 months after the procedure. You can see the remnant hypertrophied quite nicely, and there is no residual tumor. And more importantly, there is no damage to the venous outflow. Now, IRE is not devoid of complications. You know, you can have any complication, any procedure which involves placing needles inside the liver can cause complications. Pain can be a problem because you cause a lot of edema immediately after treatment. You can minimize that pain by giving the patient some steroids that can reduce the inflammatory response after the treatment. So that is something which can be managed. If you transgress the bile duct, if you put needles across the bile duct, you can still cause inflammatory temporary strictures, so something we need to avoid. And if you puncture the artery on your way in or something like that, you can also cause vascular complications like pseudoaneurysm. So it's not completely devoid of complications. You need to take your due precautions, making sure you do not transgress the artery or the vein while you're placing the needles in. Otherwise, it's a very safe procedure. Just looking at some evidence, there are several studies in the literature. They're all observational studies. There are some larger studies as well. But generally speaking, most of them usually recommend the same thing. All of these studies say that IRE is something which you could use as a supplement to microwave, not to replace microwave ablation. This is one such study where 71 patients with 103 tumors were treated, and these included both colorectal liver metastases and also primary liver tumors like HCCs. All of these patients were inoperable and also not suitable for thermal ablation because of the location of these tumors adjacent to critical vessels. And the mean tumor size was 1.9 centimeters. They treated tumors up to 4.5 centimeters. And they said the median survival is 26.3 months. And it's significantly poor survival if tumors are larger than 3 centimeters and if there are multiple tumors you're treating. So it's something similar to the conventional ablations like microwave and RFA in terms of survival figures. Okay. This is our own study which we published a few years ago, where we looked at our first 100 procedures, and you can see we treated both tumors actually, both liver tumors and also pancreatic tumors. We also treated some nodal metastases in the abdomen with IRE when that was the only site of the disease. We had a technical success rate which is close to 99.99%. We had to cancel one patient because during the procedure the patient developed high rate atrial fibrillation, so we had to abandon the procedure. What we did was we had two cohorts of patients. In the beginning, we started treating patients with just 2 needles and then changing the needle positions around to ensure that we bracket the tumor nicely. And we found that there is a much higher rate of recurrence with that sort of techniques. Now, after having that experience, what we did was we changed the technique. We regularly place 4 needles or 6 needles around the tumor. We bracket the tumor extremely well. We take much more precautions in terms of needle positioning and bracketing the tumor, and we achieved much better success rates. So our initial 6-month recurrence rates were high, so we only had a complete success rate of 65% in our first cohort, but that improved significantly better in our second cohort when we changed the technique. So what I'm trying to give you is, this is not a simple technique, it's a complex technique, and the needle placement plays an important role in making sure you get the results you'd like. Okay. Complications, the majority of them are minor, and the only one patient whom we abandoned the procedure was because the patient who developed fast atrial fibrillation. So where we go with IRE, there's lots of research studies which are going around at the moment, both in the pancreas and in the liver, where IRE in combination with chemotherapy is supposed to be enhancing tumor response rates. So this is something which we will know in the years to come. And again, IRE, particularly in the pancreas, is supposed to cause immunogenic response. And if you supplement IRE with immune mediators, you tend to get better results. Again, this is research that is currently ongoing, and hopefully we'll know the outcome of these research studies in the years to come, and we'll have a better understanding of where IRE can be used. Okay. And lastly, I'd like to summarize by saying that IRE is a new technique. It complements the existing percutaneous ablative techniques, and it doesn't replace any of them. It is safe to treat lesions which are close to critical structures. It's very effective when you treat tumors 3 centimeters or less. Anything more than that, higher rate for recurrence. Disadvantages are it's expensive compared to microwave because it involves multiple needles, And the learning curve, there is a learning curve with that which is often very steep. So you need to get familiar with the technique and needle placement in order to achieve the results you want to. We still do not have any long-term randomized trials, but we have lots of observational studies and retrospective studies which demonstrate good efficacy and safety, which is comparable to microwave or radiofrequency ablation. And as I said, future developments, IRE and immunotherapy, combination of IRE with chemotherapy and immunotherapy look very promising. Thank you very much for your attention.
Thank you, Praveen, for this exquisite. I'm here. I want to say a question. Yeah.
Take questions. Okay. Yeah. Thank you. Hi.
Thank you for this exquisite presentation about IRE. And I want to make use of what a heavy chair we have today, because we have an excellent professor of hepatobiliary surgery, Professor Amr Abdel. We have an eminent interventionist, Professor Osama Hitta. We have a great oncologist, Professor Hassan Mitwalli, and a huge educated scientific professor, Professor Muhammad Salah Abbari. IRE is not really implemented in Egypt. And I need to ask from your perspective, I know we're not supposed to take time in comments, but we have two perspectives, either PERC or open IRE. I have visited, I met Praveen before and I saw his great work, especially with open IRE. Open IRE is mainly, and also Professor Osama, we were in the same trip. Its main perspective is usually palliative more than it is curative. But the results of open IRE is much better than the results of the PERC IRE, whether for pancreas or for liver. I just need, because it seems that we are looking forward soon on entering into this new innovative technique in Egypt. Can I have a brief of what your opinion is, especially from the open perspective, in cases of cancer pancreas, locally advanced cancer pancreas, and in liver, primary liver or metastatic lesions?
Yeah, sorry.
Does it have a chance? What I mean is, does it have a chance in the local market? And also, sorry, I have to also say that we have a huge international figure in IR, which is Professor Ahmed Kamel, that also I would like to, in intervention radiology, of course, I'd like to take his opinion also.
Thank you. I think I'll just say from my perspective how, as an institution in London, in King's, how we use IRE. We have a great relationship with our surgical team, and we use IRE very synchronously, both percutaneously and intraoperatively. If there is something that can be done percutaneously, we tend to do it percutaneously. But if you think it's a higher risk procedure, it carries higher problems, and needle placement is not possible percutaneously, then we tend to do intraoperatively. We work very closely with all our HPB surgeons. I think one area where IRE has got a lot of potential is for margin accentuation for borderline resectable pancreatic cancers. So that is something which we've done a pilot study on, and we demonstrated there is a significant survival benefit, particularly for those borderline resectable pancreatic cancers when you do margin accentuation prior to doing a Whipple's. So that's one area. Within the liver as well, it expands the scope for extended liver resections. For example, the one I showed where there is a patient who's having an extended right hepatectomy but also has a lesion in a critical place which is sitting on the left hepatic vein, which is a solitary remaining outflow. So in those set of patients, you could use IRE as a way in which you can offer more curative resections.
Dr. Amr, I need to hear each comment from each one. Dr. Ahmed, of course.
Just now we have a lot of modalities for the management of metastasis, liver metastasis coming from whatever GIT malignancy, incidence of complete resection of liver tumors, or the importance of resection. I'm a surgeon. That's why it's usually we have the dogma that the resection is higher than RF or any ablative surgery. But I don't found in your presentation any comparative study, a real comparative study comparing the result of RF, especially in small tumors. You presented large lesions and the results of large lesions, but I don't find any real comparative study comparing RF or randomized comparative study. I don't think we have any randomized, but in general, if you have any idea about the results or comparison between surgery versus ablative surgery or not. This is one point. The second, concerning any lesions from the pancreas or the pancreatic lesions, if you have any results comparing the results the same for the lesions in the pancreas if we have this new modality.
Thank you. I think IRE is not going to replace surgery. It's not a substitute for surgery. I think for lesions which are, say, 3 centimeters and above, if the patient can have surgery, then surgery is the first line of treatment. Surgery is definitely the first line of treatment. And if the lesions are less than 3 centimeters, and if the patient has got comorbidities, and where you can avoid major surgery, if the patient is suitable for microwave ablation, I'm talking about liver lesions, suitable for a thermal ablation, that remains the first choice because it's simple, it's quick, easy to use, it can be done in 15-20 minutes. I'm sure all of you agree with that. But when you have a lesion which, say, 2.5 centimeters, situated right next to the main portal vein or the main hepatic vein, and the patient is not suitable for a big operation, which involves a hepatectomy almost, then you could consider IRE in those group of patients. So what I'm trying to emphasize is IRE or any ablation is not a substitute for radical surgery, resection, because surgery still carries the best long-term prognosis, but it's there to help those group of patients which are unsuitable or to extend the scope of resection when you have a lesion on the other side which is situated in a critical position. So
it's very problematic. I used to work, for example, with my dear colleague and Professor Dr. Osama Hetta for multiple cases. In our MDT, usually the decision is lesion by lesion.
Correct.
And at the same time, we consider the status of the patient. But sometimes we have a lesion subcapsular or a lesion malplaced in a position which is we have to resect a major part of the liver for doing this.
Yes.
We prefer to do some of the lesions to do intraoperative resection and the others to do intraoperative ablation.
Yeah.
That's why it's the comparison between both is very difficult. If the patient can go for surgery, we usually use it.
Yes.
If not, it's a combined work between us and our intervention radiology.
Yeah, exactly. I agree with that 100%. It's a patient by patient choice. Yeah.
Thank you for this very illustrative talk. If I want to comment on the IRE as a modality to add it in the scope of hepatobiliary intervention. I think Professor Praveen and Amr and Professor Hassan, those patients who are not amenable to definitive radical resection or Whipple with a small lesion, we can add this tool to the scope of treatment of those patients. This is one thing. And I think in the liver, IRE has a limited role. For my mind, maybe in lesion, very small lesions, if we follow the guidelines, the BCLC, very small lesion, less than 2 centimeters in segment 6, adherent to the bowel loops or adherent to the common bile duct, and we decide not to do resection, but we'll do a local ablation. We may find a role in that sector. I don't know, Professor Amr, agree for this?
Sure. No, I agree completely.
Thank you so much for your presentation, and we'll move to the, if you have any, Dr. Hassan.
To comment?
As usual, Dr. Muhammad Fawzi opened the Pandora box.
He opened the panel discussion.
Cancer patients. From my point of view, being an oncologist, a medical oncologist, it's a continuum of all these treatments together. We don't just have one modality.
Correct.
And regarding all these treatments or the interventions done now by the radiodiagnosis team versus the surgery. Surgery has been there for a very long time. All the other modalities are merging. Some of them have been there for maybe 10 years now, but I think there's quite an advance in these strategies, and in the near future, I'm a real believer in the micro-intervention no offense, Dr. Amr, with a little bit less morbidity for the patients. So I think they'll be getting the future, that they will overcome the surgery, but of course, not now. We still need a lot of studies to be done to get more and more results.
Yeah. Thank you.
Okay, thank you so much
Thank you
for
so
the
much.
presentation, and we will move to the second speaker, Dr. Ahmed Kamil, speaking about